Our next speaker, I'm just going to take about a minute to share with you a little bit about an interesting program that we recently started learning about. So yesterday, the board, Heterotaxy Connection Board, had the privilege of meeting with Ellen Miller, and Ellen's daughter, Gabriella, died of brain cancer approximately 10 years ago. Since that time, Ellen has been a huge advocate for not only cancer research, but research that benefits children with a wide range of medical conditions. And as a part of her efforts, the Gabriella Miller Kids First Pediatric Research Program was developed. This program is funded by the National Institute of Health. And essentially, since its inception, the program has generated a large database of clinical and genetic data from patients with cancer and birth defects, including patients with laterality defects. And the impact has been huge because it's allowed researchers from all over the world to share data and collaborate to investigate important research questions focused on the causes of various medical diseases. It's super easy to get to this website. Basically, what you do is you just Google NIH, or you could Google the NIH or go to nih.gov. And then in the search bar, you can type in Kids First and you will find the program. But we wanted to let our community know about this program because you might find interesting or pertinent information relevant to your child. I think Allie mentioned that you can literally type in a certain genetic marker and see what other conditions it's associated with. So if you have that information for your child, you can do that. We also just encourage you to be advocates for this program and share the information with your medical team. So we're still learning about it, but we're excited about how it might benefit our community.
Good afternoon. I'm going to introduce to you Kelly with palliative care, which is an area that many heterotaxy families didn't know they needed, or that they didn't know that was something that was available to them. So we are very excited to welcome Kelly.
I'm super excited to be here. I love to talk about palliative care. I am a pediatric nurse practitioner at Primary Children's Hospital here in Salt Lake City. I have been a part of the team for 10 years. Worked in the hospital since I was 2 billion years ago. So I started as a CNA at the hospital. I worked as bedside nurse for a lot of years and then developed the fetal heart program at the hospital about 17 years ago. And then proceeded to stock the palliative care team until they had a nurse practitioner position available. So I joined the team in 2013. So we can go to the next slide. I wish I had things to disclose, but I have nothing to disclose. I do like to tell everybody that the pediatricians for our pediatric hospice team also are the pediatricians for our community pediatric hospice team. So we share the palliative and the hospice pediatricians together. That's our only conflict. So my goal is to really teach you about palliative care and to not be afraid of it. So we want to talk about the definitions of what is palliative care and what is hospice care. And then we're going to throw in this newfangled thing called concurrent hospice, which is actually my favorite thing. I wish we had access to it for everyone. And then we'll talk a little bit about some of the diagnoses that qualify for pediatric palliative care. So what the heck is palliative care? So palliative care is really focused on the relief and the suffering of not just the child, but also their family. And we are speaking to not just physiologic pain, but we're talking about existential, psychosocial types of suffering. So we want to be able to address that with everybody in the family. Pediatric palliative care does not have criteria for life expectancy. And that's really important. That's where I think people often confuse it with hospice. That's different. We'll talk a little bit about hospice. No criteria at all for life expectancy. Palliative care does not intend to hasten or postpone death. Okay, so we're in it for the long haul with families to really support their goals. We're not driving the ship. And then it's provided by an interdisciplinary team. Who provides pediatric primary palliative care? The reality is every provider that takes care of your child ultimately does. Anybody who sits down with you gets to know who you are, understands, your goals as a family, helps you walk through the medical community, really provides primary palliative care. Specialty Palliative care is a little bit different. So it's often provided by an interdisciplinary team. So that means that there's a whole bunch of people that have different training, but work really closely together as a team. The folks on the team will have training in difficult communication, in pain and symptom management, and often ethics. And then the physicians on our pediatric palliative team are board certified, meaning that they spent a year doing a fellowship specific to palliative care. We have 2 physicians on our team, one that's a cardiac intensivist, one that is a neonatal intensivist. So they finished their training, worked in those fields for some time, and then went back and did their fellowship in palliative care. I hope I'm not the only person that recognizes this face. It's becoming a little bit obsolete. My kids just look at me like, who is this? So I'm going to speak to who are the people in this neighborhood, because this is my neighborhood, to tell you a little bit who the palliative care team is. On our team, we are an interdisciplinary team. So we have 6 physicians. We have 4 nurse practitioners, and one of them. We have 2 nurses that help with our continuum of care. We have a chaplain. We have a child life therapist, and then we have a licensed mental health counselor. In the past, we've had a social worker. We're trying on some different roles because of this particular person's expertise in trauma and grief work, which we felt was really important to our families. So what do? This is me. This is this giant old growth tree in Great Basin National Park. When I was first learning about palliative care, it was described to me as this tree, and there's all these different gnarly branches on the tree. And there's some kind of scary things that are on that tree, right? There's end of life care. There's this advanced care planning, but they're just a branch on the tree. There's all these other branches on the tree that we're going to talk about. So the first and foremost is that we really want families to feel comfortable in their child's diagnosis, their prognosis. And I think it feels like families got dropped in a new country with a different language, no interpreter, and no tour guide. That's how I think it feels. And so what we hope to do is really help families navigate what this journey might be like. So that might be to help interpret and to help, provide that tour guide through what this new life of medical complexity can be like. We will do things like sit in on clinics, so co-visit other specialty clinics so we can hear the information with the family. Scary to hear information. Sometimes at the beginning, it's hard to be comfortable like speaking up and asking and saying, what's that word again? Could you write that down for me? Can you draw that picture for me? So helping families be comfortable asking to hear the information again. When we hear information, particularly in a big group, when we're emotional, we hear like 10% of what those providers said. So it's reasonable to say, let's talk about it 9 more times so that we feel like you get a little bit more comfortable. So we'll do clinics, we'll do care conferences, we do bedside rounds, we do a little bit of everything, and that's based on what that family needs to feel competent in understanding their child's diagnosis. The second step is really to understand what drives a family, who they are, what's their value system like. So we call this goals of care. It's just kind of a fancy way of saying, tell me what gives your child the very best life possible, knowing what we know about their medical condition. Sometimes I ask families what they hope for most, what they worry about most. We talk in context of care that is for your child, not to your child. And that goals of care, they're going to change over time. Your child changes over time. You change over time. Your circumstances change over time. Your goals of care should change over time. So things that you think are the right fit when your child is 2 months or 2 years old might be really different when they're 12. So we want to constantly be addressing what is it that gives your child the very best life possible? What are your goals for your child? Oh, sorry, go back one more. The other part of that is the continuity. And from so many conversations with family, what they really get frustrated with is that, the specialty teams, they change every week. So your ICU team changes every week. Your cardiology team changes every week. Your hospitalist team changes every week. Your pulmonologist is going to change every week. Everybody changes every week. We don't. We stay the same. So even amongst our team, which we carry a census of about 60 to 80 kids a day, we've split ourselves into kind of two small teams. And my team covers the SICU, the cardiac step-down unit, the fetal center, a couple of those things. So you're going to get to know some of the same faces, maybe my face, a lot. And that's going to be helpful to you because you might see me in the cardiac ICU. You might see me on the step-down unit. You might see me in the emergency room. You might see me in clinic across the street. We will get to know each other. So we develop rapport and relationship. So when we do have to talk about hard things, we already have that relationship. It doesn't feel quite so out of sorts. The next, oops, sorry, I'm not done yet. Yeah, I am done actually. That'll be good enough. There we go. So when we talk about medical decision-making, because that's kind of like the third realm of what we do with palliative care, we really have to turn it back to what are your goals? So your goals of care become your roadmap. And I often hear families say to me, like, well, what would you do? And I have to flip it back and say, but that would be really different because my goals might be really different than what your goals are going to look like. So those goals of care that we readdress and talk about drive your medical decision-making. None of us can see the future. I've tried, not done a good job at it ever. But what I do know is that you guys know your kids. You are your children's experts, and you will know when your goals shift. And that will then drive that medical component. The other part about medical decision-making, and this is where sometimes those scary conversations can come in a little bit, is that what your goals are for your child, how you're making those medical decisions are also going to impact how we choose code status for a child. That is both in the hospital and outside of the hospital. And those are kind of, especially in kids, two different realms. And so I want to talk a little bit about that a little bit towards the end. But one of the other things I often ask families, even if I'm not worried that their child is going to die anytime soon, I want to know where their preferred place of death would be. Because man, if we get to the cardiac ICU and you're intubated on all these pressors, it's really hard to get home. And if being home is what is most important, then I'm going to be really thoughtful, a bunch of steps upstream to say, wait a minute, let's talk about this before we get there, because I know that that thing is really important to you guys as a family. So comprehensive pain and symptom management recommendations. We are a consult service, so we're not the primary team. Primary team is always the team that's writing the orders. The consult services are making recommendations, and then the primary team can choose to take them or not take them. So we do a lot of assessment of your child's discomfort, not just pain. Are they pooping? Are they getting their typical bowel program? Do they have issues with spasticity that haven't been addressed? Do we have neuroirritability that hasn't been addressed? So we want to look globally at what's going on with your child. But then we want to do spiritual assessment. We want to do a psychosocial assessment and be able to provide resources, not just to your child, but also to the rest of your family, so that they are also well cared for. Okay. Made these slides for a presentation I did for the Heart Center. And so some of them are good and some of them are not. I'm using them as a little bit of a skeleton. So back to that continuity and longitudinal support. When you get referred to the palliative care team, you get a team that's in it for the long haul. So it's not just that admission. It's not just that clinic appointment. If I meet you in the fetal center, then I'm going to follow your child until either they transition out of the pediatric world or until their death. So we follow families every admission, every single time. We'll check in and see how you're doing. We do outpatient clinic appointments, and we do those by families telling us that they need us to come, or a provider that says, gosh, we got to talk about some hard things. Will you come to clinic with us so we can talk about those things? The other component is with COVID, we were able to start doing a lot of virtual visits, and our team works a little bit differently than other teams. The team is funded by the hospital, which is Intermountain Healthcare. Our physicians are funded through the University of Utah. And so the staff are funded either grant or foundation or different ways. So I don't bill. I'm just a wrapped in service for your child when they're in the hospital. So for me, I can do virtual visits for any state, and we cover a 5-state area, which is different than a lot of other locations. Our physicians are a little bit more tricky. So we really try to tailor some of that continuity to families as well. We also help families get connected to resources. So a lot of new families who've not chosen a pediatrician before. So we want to help families get connected into a medical home that's going to help support their child's complexity, help families get connected to other resources that might be in their community. Talk about things like different waiver programs that are available in different states. So we do a pretty comprehensive sort of assessment also of where your kind of location that you live and what are the things that you would need. We do a number of parent supports as well. We have a parent Facebook group that's a secret group that we invite parents to be a part of if they choose to. It's a place to network. It's a place to share information. It's a great place to say, we just got a G-tube. I've taped it this way 4 times and I can't figure this out. And you'll get 20 pictures of every other parent with their child's G-tube that will show you how they tape it. It's a place for parents sometimes to share equipment. You all know when you change formulas and you have 42 boxes sitting in your back room, that 42 boxes has nowhere to go. So sometimes families will share equipment like that. We, prior to COVID, had a parent lunch hour. It was my very favorite thing that we did. And parents would come, we would provide lunch, everybody would sit around and we would sometimes talk about a topic, sometimes talk about movies, but it was a really nice place to be together and to connect that wasn't at the bedside. That went away with COVID and with the ongoing renovation that's at the hospital. And we don't have a large space anymore. And so we haven't been able to get lunches back up and going. So we're doing some parent hours in the afternoon and some things like that. So we are continually trying to create community for families so that they get the opportunity for that sort of shared meaning experience. And then bereavement support. We follow our families even after their child has died. Our team follows families for 2 years. That means not that much because you could call me 10 years later and say, hey, do you remember when this thing has come up for us? I'd really like to talk about it. Or, you know what? My child started doing this and it's really weird and I don't know what to do. I don't even know how to answer. So then we might, sit down with a child life therapist or do a virtual visit that way to kind of talk through what would be the recommendations or how can we help you guys navigate where you're at. The other part that you guys wouldn't know that we do a whole bunch of staff support. So we're always available to the other teams who are providing that primary palliative care if they just need a little help in how they need to have a conversation or what their resources are. But also we have 2 to 3 learners with us almost every week. We have a fellowship program where we have both adult and pediatric fellows that rotate with us for large chunks of their time. Okay. So let's talk about the difference between palliative care and hospice. So starting with palliative care, like we talked about, it can be provided in any location, right? It can be in the hospital, it can be in the clinic, it can be on the phone or virtual. In many states, they have home-based pediatric palliative care teams. We do not yet. We will at some point in time. We do have adult palliative care teams that do home visits. So they can happen in any location. You can continue a medically aggressive pathway while receiving pediatric palliative care. There's no life expectancy, 0, right? Because we are not hastening death. We are just supporting families for their goals of care. And really, we do look to help with symptom management that really compromise quality of life. That's really what we're looking to assist with. So over here, if we look at pediatric hospice, the difference is here. So hospice by definition is really a home-based therapy. Oftentimes the hospice team will look quite a bit like us, but the interventions are focused on comfort. So sometimes that means declining some of those really aggressive things. Sometimes it means like slowing down your feeds to half your goal because that's what's comfortable for a child. Hospice by definition also and by regulatory law can only be provided to someone who we think might have 6 months or less to live. Now, again, we're terrible at prognosticating. So that being said, I have a kid I follow now. He's been on hospice for 4 years. So because he continues to have declines, he continues every time with whenever it comes up for recertification, he qualifies. So he continues to receive that benefit. And then the pain and symptom management, again, is focused on alleviating suffering at end of life. Okay, then there's this really cool thing in the middle now. So before about 2010, we had two care pathways: medically aggressive pathway, which included pediatric palliative care, and hospice. When we got to this, whatever this crossroads is, we decided it was time to transition for end of life. Then this new thing came along. You can go to my next slide. So in 2010, with the Affordable Care Act, a new law came into place that any child who is receiving Medicaid as a primary or secondary insurance, that could be on a waiver, that can be a CHIP program, doesn't matter, as long as you've got Medicaid as some form of your insurance coverage for your child, they qualify for concurrent care benefits, allowing them to have sort of this middle of the road care package. Now, we do have to say, yes, I would not be surprised if this child died in the next 6 months. But there's a couple of things that are really beautiful, I think, about this structure. One, it really allows time for that team to get to know you, your child, your family, and have a good sense about what do you guys need? What makes you tick? What's helpful? Which people on the team do you like? I have families that are not religious, but man, they like the chaplain, and that's the person, that's their person. So it allows families to really develop rapport over a longer period of time versus somebody coming in for 1 week because we're that close to end of life. Implementation is a little bit different from state to state just because Medicaid gets dispersed a little bit different state to state, but the overarching, components are the same. The other thing that I want to mention is that this is not a benefit that's available to people with commercial insurance or private insurance, except for the caveat that over the last few years, we've had a couple of commercial insurance companies locally who have seen the benefit for families, because it often can be a way that kids avoid the ICU, they avoid admissions, and in the end, it's actually cheaper for the insurance company. And so Select Health, which is a local company for us, Blue Cross Blue Shield, they are offering concurrent care services to their families with commercial plans locally. The other benefits is that you have a team that's on call 24/7. You have somebody to call. So that'll be a nurse that gets to know your child. They'll be your main point of contact. And there's always a physician on call. You get kind of a whole package of folks, and it's a little bit different depending on where you live. So you'll get some care management, and you'll get help with equipment and medication ordering, sometimes pharmacy benefits. You might get a CNA that's going to come in and help with ADL care. You might be lucky enough that your team has a music therapist or a child life therapist on there. Most teams will also have that social work and chaplain available as well that will be visiting. I think the other part is that it's a little bit more of a relaxed environment for families to continue the conversations around what their goals are. Because we don't know how things are going to go in the future, your hospice team is home. They're home with you. They're kind of seeing what's happening, and they have the opportunity, as your child is evolving, to continue those goals of care conversation. Do you want to go back to the hospital? Do you not want to? If you don't want to go to the hospital, how do we want to take care of your child at home? Being on hospice or concurrent hospice does not say you can't ever take your kid back to the hospital. You can. So I want you to know that it doesn't take that benefit away. It just gives you some extra support, particularly in the realm of decision making. Hospice is great in that when your child dies at home, there's no emergency. There's no call EMS. There's no lights. There's no craziness that goes on. You just call your hospice team. Some families want the team to be with them when their child dies. Other families don't. Either way is fine. The staff has to come to your house after your child has died. They have to sign the death certificate, and they're going to help you navigate, what do we do now? What happens is that the funeral home comes to your house when you're ready. It's not an emergency, and will then take your child's body to the mortuary. And then hospice continues to provide bereavement support for families, often for a year or more afterwards. So they come to your house. The social worker comes to your house. The chaplain comes to your house. They work with you. They work with your kids as you guys work through your grief process. And then the other little caveat is kids graduate hospice too. Again, it's nothing that's set in stone. Once in a while, we have kids that do better than we expected. Sometimes we're using a concurrent care option for a child in a particular period of time that we think, say, for example, they're waiting to get to their second stage, Glenn, and they're very high risk. We don't know if they're going to survive. Family lives maybe in a more rural area. And if they had an arrest at home, things wouldn't go very well. And so sometimes we use concurrent care hospice kind of as a transition, really to support that family in this kind of murky area where we don't know how things are going to go, but we want to make sure that they're really well supported. And then they make it to their second stage and they have that surgery and they do really great. And then we graduate them from hospice. Kids can be re-enrolled at hospice at any point in time. And so it's not, you didn't like use up your benefit or anything like that. It'll be back. It'll be there when you need it. Okay, now we can go. I love to talk about perinatal or prenatal palliative care. I mentioned that I developed the fetal heart program. And so it's really one of my big loves in life. I love those long-term relationships. I have kids I'm following now that I met in fetal heart center. So they were little ones growing in their mom's bellies. I have kids that I met when I first started with the team. So I'm following really long-term with a lot of these kids that I've known a long, long time. The goal for perinatal palliative care is really to help families through pregnancy management and coming up with a delivery plan. And if a family, this particular slide, the next two talks a little bit more, if a family has shifted away from medically aggressive pathway, how some of these things can be helpful. We're really great at getting all of these pictures and doing this diagnostic workup these days prenatally, but they're these pictures. They don't actually tell us how a kid's going to behave or how they're going to be when they pop out. So that there's a lot of uncertainty. Being able to meet families really early, again, this whole rapport thing, you're catching the theme, like developing rapport with families helps them to feel comfortable with these ongoing conversations. They get to really understand the factors that are going to drive their child's care. And then I think it also allows families to kind of just have some time to be with a diagnosis that's really complicated and allow them some time to decide which way do we want to go with this? What seems to sit best for us? I often have families, and I use this analogy, we're going to try these medical pathways on like a coat. You know, we're going to talk through like this medically aggressive pathway, and then we're going to talk through maybe a comfort focused pathway. Sometimes we have a middle of the road pathway too. So it's going to be, you know, you, your husband, your partner, whoever your people are, put it on, try it on like a coat for a couple of days, walk around in it, shake it out a little bit, write down what comes up. What do you worry about? What are you hoping for? How does it feel? And then we're going to talk about where you guys are at when they come back to see me. Families who have chosen a comfort-focused pathway from a perinatal period, things that we have found, they have little or fewer days in the ICU. They have less procedures and avoid CPR on their child. And then they end up just using less resources in the hospital community. Families who get to be involved in that early decision-making actually trust their providers more. They have less regret. They get more bonding time with their child. And then when we talk to bereaved parents, the things that they speak about were, one, we had time to do memory making. And that theme of continuity comes up again. Like it was the same group of people that knew us when we were pregnant, helped us with delivery, and then took care of us afterwards. So that continuity is really important. Okay, sorry. So I'm going to speak to our fetal center. So our fetal center is called the G.S. Bonham Utah Fetal Center. It's named after a family who gave a very large donation to the center. The Fetal Heart Center has been around since 2007. This is everything else, sort of wrapped into two windows. So we have kind of two arms where we have the Fetal Heart Center, and then we have everything else that could possibly be diagnosed prenatally. Our clinic includes maternal fetal medicine or perinatology, a neonatologist, and then all of the specialists. So we'll have some RN coordinators who will help families, but then we get all these other specialists in addition to the fetal cardiologists. And they will come back to the center multiple times to have imaging done, expected pregnancy management, and then ongoing conversations with all of these specialists so we can continue to plan how we're going to take care of their baby after they're born. think the other thing that I really love to talk about is this idea of anticipatory grief. And I'm really glad to have this term because I know a lot of moms talk about it with me. And for a long time, we're like, what do we call that? Like, what's that thing that where I'm already worried about things, but my kid's not even here, or they're not sick and they're not going to die anytime soon. But this idea of anticipatory grief is really real. And it gives us the opportunity to start some of that processing early on. This longitudinal support, again, that continuity comes in, particularly when we're talking about these hard subjects like anticipatory grief. And then I just want to tout myself just a little bit. In 2016, I only saw 10 patients. In the second quarter of this year, I saw 30 patients. So I'm seeing about 100 patients a year. You can go to the next slide. And so how that reflects to the cardiac population, I see every pregnancy with a single ventricle physiology, every pregnancy with a baby that's diagnosed with heterotaxy. So yay, it's a lovely thing. Some of the other kids that we're seeing in the cardiac world, so kids with cardiomyopathy, every family that's considering a cardiac transplant or considering a ventricular assist device as a bridge to transplant. We see all of those families and follow them in the hospital. And then any child that has a cardiac diagnosis in conjunction with multiple other things are who we're going to see. Okay. So this is kind of another way of thinking about who gets palliative care. And I'm bringing this up because you guys are a community of moms and dads who have other families who have medically complex children that don't just have heterotaxy or congenital heart disease. And so these are some of the other diagnoses that we might see pediatric palliative care being helpful. So places where we have life-threatening conditions where curative options are available, but they might fail. Progressive conditions that don't have a curative treatment, irreversible, non-progressing conditions, and then conditions where premature death is inevitable. Okay. And so we just throw some of these in just to see where they fit and line up. So you can see that, progressive conditions, single ventricle physiology will land there. Other things like muscular dystrophy will land there. Life-threatening conditions. We will often get consulted on kids in both the cardiac and the pediatric ICU if they are on ECMO, because it is such a high-risk therapy that there's a number of sequela and goals of care conversations that need to be had as a part of that therapy. Conditions where premature death is inevitable. So all of our trisomies 13 and 18 that we're seeing a large population and offering cardiac interventions at our facility for. Kids with multiple anomalies here. And then irreversible, non-progressive. And so those are often kids who were born very premature. And then some of our post-heart transplant kids. Some of the key challenges, particularly with the cardiac kids, are that our technologies have increased, our skill sets have increased, and so our risks have increased. So we're seeing greater mortality associated with some of our surgical procedures. We're often having to have conversations about dependence on medical technology, such as tracheostomy and ventilator, before agreeing to a cardiac surgery because they have to be taken as a package deal. And then, yeah, that's good enough on that one. Thank you. So I want to talk about code status a little bit because I think it's a little bit of a scary topic. I also think that there's a lot of cool things about particularly this form that a lot of families don't understand. And I think it's knowledge is power. So when we talk about code status, you hear it a lot in the hospital, right? Well, there's also another venue in the community that's a little bit different. So in the hospital, when you come into the hospital, we should be addressing code status with every single admission. And it's real time. It's based on who your kid is, their current quality of life, and why you're at the hospital. Was this a planned surgical procedure? Well, most families hope to leave in the state in which they showed up. Does your kid, have a really severe respiratory illness and you've had 10 admissions already this year? Well, that might be a different conversation. So code status in the hospital is in the here and in the moment, like we're making real-time decisions. This is different, okay? So the name of this form is a little bit different for every state. The state of Utah, ours is called a POLST form, a provider order for life-sustaining treatment. So your state might have something a little bit different. This is different than an advance directive. So an advance directive is when you name somebody that knows you well, that's going to speak for you if you can't speak for yourself. So that's great when you're over 18 years old. As parents, you're already the advance directive for your child. So that's not going to be helpful for us. This is a portable set of medical orders that follows your child anywhere outside the hospital, actually into the emergency room before you get admitted. It's going to be a form of these orders is going to follow you throughout these areas and really help guide conversation. The reason I like it so much is it really acts as an insurance policy to allow parents to make decisions that they think are important for their child. So I don't have the Utah form up here, but all the forms cover the same amount of information. So some of the topics that are covered are, what would you do if you woke up in the morning and your child had already died? Would you want to start CPR or would you not want to start CPR? And so you start to think about, okay, most of us, our goal is to protect our child from pain and suffering. If they've already died, would I want the rest of my family to bear witness to a situation like that? Most families tell me no, but some families tell me yes. And I say, you know what? I'm not the one that's got to look at myself in the mirror every day. I really support you being able to do what you think is very best for your child. So we would fill that form out accordingly. And then the form asks a number of questions after that. It says, you know, if your child is still breathing and they still have a pulse, here are some options that you could choose. And it ranges 3 different categories. 1, full treatment, cardiac ICU, putting in a breathing tube, being dependent on a ventilator, CPR, shocks, meds, IVs, all the things that we can do in the cardiac ICU. Then there's this middle of the road called limited additional interventions. I tell families it looks like being on the floor. We don't do CPR on the floor. We try not to. We don't put breathing tubes in on the floor. Oxygen's okay. We do antibiotics. We do imaging. We do lots of other things on the floor. And then the third choice is called comfort care. And it tends to be more of a focus on staying home and allowing for end of life. How these forms work is that you can always escalate up from your choice. So if you chose comfort, you could have everything else above comfort, right? So you could go to the hospital, but you could say, I want to avoid the ICU. You can even go to the ICU. If you don't have this form, and this is the part I think parents are kind of taken back by, you can't make decisions for your child in the community. So if you call EMS and they come to your home, they don't know who your child is. They probably don't understand your child's diagnosis because they're mostly trained in adult resuscitation and adult care, which are, heart attacks and strokes and things like that. And they don't know your child's past medical history. So they're really not even a good person to help you make decisions. You guys know your kids best. You probably know what their quality of life was like leading up to whatever this event was. So you're in the best position to be able to direct EMS the types of interventions that you think are not going to be burdensome and are going to maintain your child's quality of life. So this is where this kind of like conversation about insurance policy comes in. It allows you to make decisions from a legal perspective, and it allows you to make decisions that protect your child. So if anybody wants to talk more about this, especially the Utah form, I'm happy to talk more after. I think it's a really important conversation. I think it's hard. I think it's a hard conversation. I think it's harder to have when we have to have it. I'd rather have this conversation and talk through it when we don't have to talk about it. It gives you the opportunity to understand what's the vocabulary? What does it mean to talk with your loved ones about the choices that you might make, and really have some sort of planning in place and feel comfortable when you do show up to the hospital to have the conversation with your medical team. I often tell families they're probably going to see that you have a pulse form in your chart at some point. You should bring it up. You should ask to talk about code status before you get the resident that comes in that's really uncomfortable and doesn't know how to talk about it with you, and it ends up being a really awful conversation. Some of the things, and all the forms are a little bit different. The Utah form they only ask one parent to sign it, but they ask 2 providers to sign it. Idaho's they're all a little bit different. So will need to get the nuts and bolts about where you guys come from. Yep, there's nothing on there. So just to finish up or circle the wagons, palliative care is really focused on minimizing suffering for patients and families. really at any age and stage of illness. Everybody provides primary palliative care, but a palliative care team will provide that specialized palliative care. And that is best provided by an interdisciplinary team. And then I think kids with single ventricle physiology, kids with heterotaxy, they're really good candidates for palliative care. And I think it offers a really big added layer of support, both for that child and for their family. And then, some of these advanced care conversations are better had early than later on down the road. So I want to find out what questions you guys have for me about any of these topics. Or anybody online? Hold the phone.
Our Zoom.
Yeah, they got to hear. Yeah.
Hello.
Hello.
Okay. One of the questions is there's many people listening in from all over the country and maybe outside the country. But within our country, how do we seek out this resource?
Pediatric palliative care?
Yes.
Dr. Google is always a good place to start.
Okay.
I would start asking your people in your specialty groups, your pediatrician, your cardiologist. We get families that call our office all the time that are self-referring, and then I will turn around and call their pediatrician or call, one of their specialists just to say, hey, we're going to take this family on. Is there, things you're worried about or things that you think we can be helpful with? So, I think it's just investigating what's available in your area and reaching out and asking for it.
Okay. And I have a follow-up question.
Yeah.
So let's say that we find that we have access to this where we are.
Yeah.
And there's some of us, us included, where this would have been really fabulous to have access to when things were really, really rough. And then now we're in this beautiful place, but we're not promised to stay in this beautiful place.
Right.
So it could be something we could access later, but I'm seeing that it would be something to be beneficial to access now while we're still in a beautiful place.
Yes.
I mean, if we were here in Utah, it sounds like that wouldn't be hard to do. But some of us in other places, we might have to do a little advocating to convince someone that what appears to be perfectly healthy child walking down the street would need something like this.
Right.
So can you speak to that at all?
Yeah. I mean, I think because there's this misconception that palliative care is like hospice, that you need to be like at this cruxy stage towards end of life to access palliative care. And that's not the case. It's often a misunderstanding about what palliative care is. I would rather meet you when we don't have to have critical conversations. It is such a better time to get to know a family when they're not having to make decisions for their child. I did a consult in the SICU yesterday, and I was like, I hate it. I hate it in here. This family's very upset. They're very anxious. There's a million distractions and things going on. It's not the right time if I got to choose. And so I think knowing what you know about palliative care now, that you can advocate that it's better at a non-critical time so that people can get to know you, assess your resources, kind of get ready for when there might be something that comes up.
Hey, do you have any advice or suggestions for how to get other members of the team on board with the palliative approach? I have a lot of back and forth with our care team about, I don't think this is necessary. I don't want to put my child through this, et cetera, because they have a really hard time understanding like the palliative angle.
So, not everybody needs to be on board to some degree.
Well, then there's other implications.
There might be, for sure. I think it still comes down to education. And sometimes the palliative care team can be the advocates for you into helping educate those other people. I think that's tricky for you. I mean, that shouldn't be your job, but it is. So I think if you can get one person to get on board with you and get your palliative care team consulted, then they can help you to have those conversations. that's how I've seen it work best.
Okay.
Okay, so that's specific to our team because I didn't really talk about this. So we don't have an outpatient clinic. So if we make medication recommendations, there's no place for a family to like follow up for us to refill their prescriptions. So this is specific to us. We make recommendations to the comprehensive care clinic. We make them, inpatient to all of the different teams. That's going to change for us when the Lehigh Hospital, which is a new pediatric sister hospital for primary children's, will be up and running about an hour away from here. We will actually have our first clinic that will open up our outpatient clinic. And we'll have a full team at the Lehigh facility as well. So there's a lot of other palliative care teams that do home visits, that do clinics. So that's the part that's going to just be different amongst the teams. For us, we have a big team, but we don't have enough coverage to be on nights, holidays, weekends, and be able to manage the outpatient needs of our families. So that's specific to our team. So depending on a family, as we get to know each other, what are the things families need? So sometimes it's processing information with medical staff, sitting down and talking through it. Sometimes there are spiritual components for families where they're angry at why they're in this position. And so it might be working with our chaplain. I think despite what your faith backgrounds are, I think it's always hard on families to have complaints or anger in their own religious circle, because I think it sets them up to maybe not get the resources that they need. And so they should utilize ours, who isn't going to judge them or, have any sort of personal vendetta or worry or anything else. I think so using the chaplain, if there's something such as that. We have our licensed mental health therapist, who's specific to grief and trauma. So working with families who that seems to be the best fit. Our child life therapist is available for kids, but also available for siblings. And so using them to help navigate, if it's talking through kids understanding what to expect, grief, and then it's also resourcing families for maybe more long-term needs for any of the above concerns.
I just wanted to touch briefly on that as well. We had the opportunity of having outpatient palliative care when we lived in Illinois. And then we moved to Utah. We met Kelly and had the inpatient. Outpatient for us was phenomenal. They set us up with a company, like a nonprofit that would send out a cleaning company to my house once a month and just do a deep clean of my house. If we were in the hospital, they would plow my driveway for me. They sent out a child life specialist a couple times a month. And she asked me, what are your concerns? And my concerns were, my kids don't know how to be together. I constantly am pulling them apart. How do I bring them back together? And so she would come and plan activities to work with all of my kids and help them work through things. She would take them one-on-one and let them express and vent those things. In the hospital, it's not just about your child with heterotaxy. Your other kids are suffering too. And, whether it's a special trip down to the playroom to make a special gift for that sibling when they're younger, or, I know our hospital gives passes to the zoo, or you go check it out and away you go. And you can get there and go spend an hour or two with your healthy children and still get to be the parent that you need for all of your children. So there are so many benefits of both outpatient and inpatient that I really encourage all of you to seek that out. And even if, to Jenna's point, they don't all have to be on board. As a matter of fact, I went to Kelly a couple years ago and I said, Kelly, I can't do this. Like there's something going on and they are not listening to me. And I'm going to lose my daughter. If something does not change, I'm going to lose her. And Kelly went to the team and said, we've got to fix this. How do we fix this? And we ended up with a new comprehensive care doctor. We've worked with some new doctors. We have a phenomenal team now, but that's all because our palliative team stepped in to help me manage this. For me, comprehensive care has been like the quarterback that I just say, here, you take care of everything. But Kelly and her team for us have been that guiding force behind it to say, you know what, let's not lose focus that we want these kids to have a quality of life. We need to let them enjoy life too amidst the struggles. So it's been a huge, huge blessing in our lives.
I just wanted to bring up when you talked about the post form and how it's different in every state. I don't know how you guys manage, but I know like for some of us, you might live in Georgia, but have medical care in another state. Our experience, and I don't know, but probably for Utah families, maybe you can explain, our experience with that was I carried in Massachusetts, it's called a MOST form. So Massachusetts Order for Life Sustaining Treatment. My experience was I could take that. It's not valid in other states. It was only valid in Massachusetts. But when you had one, like when we had to roll into an emergency room in Florida, when she was very critically ill, I had our MOST form with us, and they had somebody come in and basically translate it to Florida legalese.
Right.
And, you know, if they had to pull in two physicians there, I feel like encouraging people to understand that like it opens an avenue to garner a lot of cooperation, because I will say it's an opposite thing. When you roll into an emergency room in a state that you don't belong to, they're not looking to second guess why you have a MOST form.
Yeah.
Like they understand you have it and they want to figure out what it is that they can do to honor the wishes that you've already had. So they are all different in every state. And if you needed to initiate palliative care, and that's why, like you said, maybe you could talk about how that would look if it's family comes from another state in Utah, but
Yeah.
I feel like it's a really, truly, truly beneficial thing to have, because I have to second, it does then all of a sudden put a lot of power back into your hands, in the sense that now you're sitting there and people are asking you, what is it that you think would be best to do in this situation?
And it again, it doesn't take away any of your choices, right? It only adds to. So for us here in Salt Lake City, we actually are really the only large pediatric trauma center in a 5-state area. So our catchment's large. And so our state's same situation. It's not a legal document for that state, but it's honored in our surrounding states. So families that I know are back and forth from Idaho, they have a Utah form, and then I send them with the Idaho form. We fill it out the way that we filled out the Utah form, but I can't sign it because I'm not licensed in Idaho. They take it to their community pediatrician, or I call their community pediatrician, or their cardiologist that's seeing our families in Billings, you know. So I make sure that I'm communicating and helping them express themselves, because I think it also feels weird that they show up with this form and, you know, the other providers have like not had any of those conversations with families. So I try to help them set the stage for being successful. And we have families that have multiple forms because they are back and forth between different states. If they live in Montana, they're driving down throughout, you know, they're depending on their route, they might have them in various states if they're spending big chunks of time there. So yeah, the other thing is that they don't live on an electronic cloud. So, you know, in the world of electronic medical records, this form will live in your child's electronic medical record locally here. So if you were to go to the Lehigh Primary Children's or the Salt Lake City Primary Children's or one of the other Intermountain clinics, we'll find it. It'll be there. If you go to one of the university hospital clinics, it's not going to be there because we have different EMRs. It doesn't live on electronic cloud for the state of Utah. So the county sheriffs, the different, you know, EMS agencies, all these folks that show up to your house, they don't see it. They don't know you have it. If you don't want to use it, you don't have to get it out. They don't even know about it. So that's the first part. If you want to use it, then you got to pull it out. And you can also say, I want you to do X, Y, and Z, but here's my line in the sand. Or I'm willing to do that for 2 minutes, but I'm not going to do it past that.
So we filled one out for Eliza years ago. I don't even know what's on it, but we never got a paper copy, and I would love to review
Well,
it.
you and I can
So I
talk.
can remember what I said. But how do I get that? Do I?
You call me.
Okay, so you would have it in your records?
I hope.
I hope so too.
Yeah,
Okay.
it should. I
And
hope.
then how long
yes.
does that last?
They don't expire.
Okay.
Yeah. So
All
if
right.
we did it before 2013, the state did a new form, and I've tried to update everybody's forms as they've, like, you know, as I've seen them. So I don't remember when we did Eliza's form.
It was at least what,
It was probably with
14
my
around there?
predecessor. Yeah, my old people, Tony in that group and Beth. And so it should be in her electronic medical record.
Okay,
If it's there, I can print a copy if it still supports what your goals are. If not, we do a new one.
Okay,
And we
we'll
can
get a hold
actually
of
do them
you.
electronically through her record. We can do it on the phone actually and do it that
oh,
way.
perfect.
Yeah,
Thank
there's
you.
some cool things we can do now. Is there any other questions? Thank you so much for having me. I really enjoyed getting to come.